thank you, all three of you guys, for being here. So I'll go ahead and start. I want to keep it on time as much as we can. I'm Michael Lavers. I'm the international news editor for the Washington Blade. We're the oldest LGBT newspaper here in the United States. And we've been publishing since 1969, so we've really had a front row seat to LGBT issues, both here in D.C. and around the country and around the world for over 40 years. So we bring that perspective to this. So we're going to be talking about health, privacy, and the LGBTI community with this conference as the backdrop. So I think it's really an important topic to talk about for a number of different reasons. Most notably, we're at the 35th anniversary of the first cases of what became known as AIDS that we just not celebrated, of course, but marked a few days ago. The Affordable Care Act is now law, and then we also have a number of transgender and intersex-specific issues that are becoming increasingly public and increasingly at the forefront as we talk about this. So those are three of many things that we're going to, hopefully discuss today. So I want to introduce our panelists real quick, and then we'll go ahead and get right into it. To my immediate right is Kellan Baker. He is with, he's a senior fellow with the LGBT Research and Communications Project at the Center for American Progress, where he works on a range of LGBT health policy issues across the Department of Health and Human Services. Kellan also directs the Do Ask, Do Tell project, which supports the data collection of LGBT-specific information in electronic health records, and is also a founding steering committee member of Out to Enroll, which is a nationwide initiative that works to connect LGBT people and their families with their new coverage options under the Affordable Care Act. To Kellan's right, or left rather, is Samantha Crane. She is the legal director and director of public policy at the Autistic Advocacy Network. Her work focuses on promoting health inclusion of people with disabilities in the community, including access to health care, community-based supports, and services that include combating stigma and elimination of accessibility barriers. She's written and spoken extensively on this topic, and also the intersection between mental disability and healthcare decision-making, which includes the right to privacy and self-determination. And then finally, last but certainly not least, is Tamar-Mattis. She is the founder and legal director of Interact, which is formerly known as Advocates for Informed Choice. And that's the first organization in the country focusing on legal advocacy for the civil and human rights of children born with intersex traits. And she's currently serving as a counsel in a case representing a boy with intersex traits who was given, correct me if I'm wrong in pronouncing this, feminizing genitoplasty, is that right?
Mm-hmm. That's correct.
At 16 months old while in state custody. And she also teaches at the University of California, Berkeley School of Law. So we have quite a panel here today, and hopefully more folks will be trickling in as we talk. So I would like to give our panelists each a few minutes just to talk about their work and how it factors into this idea of health privacy in the LGBTI community. So, Kellan, I'd like to go ahead and start.
All right. Thank you so much, Michael, and thanks to all of you for joining us. Since we're a small group today, we would love to make this interactive, so please don't be shy with any questions or comments at any point during my presentation or short remarks. As Michael mentioned, I'm at the Center for American Progress here in Washington, D.C., where I work on a range of LGBT health and data collection issues. So I really struggle with the tension between data, wanting to collect it, wanting to have it, wanting to use it, and the very real concerns that so many in LGBTI communities have about discrimination and about the use of that data. So one of the biggest opportunities that we have had to advance the discussion around data collection is actually in the electronic health record space with the Meaningful Use of Electronic Health Records program. It was part of the HITECH Act, the stimulus act that was passed in 2009. And what it does is provides incentives for Medicare and Medicaid providers and hospitals to shift from paper records to electronic records with the goal of having more and better access to more and better data in order to improve health outcomes both for individuals and on a population level. In 2015, the regulations for the third stage of meaningful use came into effect. They will actually become operational in 2018, but what we're looking at is a requirement that the certified vendors' systems, so electronic health records that are certified under Stage 3 of meaningful use, must have the capacity to collect, record, and store data on sexual orientation and gender identity. Importantly, that doesn't mean that any healthcare provider has to collect that data, and it does not mean that any LGBTI individual has to provide that data. But it does provide for us an opportunity to start talking a little bit more about why it is so important for us to have data about who we are as LGBTI individuals, what we need from the healthcare system and from our healthcare providers individually, and how do we do that in a way that, as Michael was mentioning, there are so many things that are happening now on the national level and in the states that are really threatening the lives and well-being of LGBT individuals. You look at laws in North Carolina, in Mississippi, in Tennessee, all of these attempts to strip LGBT people of the protections of the law. And what does it look like to have that going on at the same time that you're saying we really want more LGBTI people to identify themselves in what is already such a scary place for so many of us as patients in healthcare settings, in situations where we may have already experienced discrimination before. So I will be happy to talk in more detail about sort of what that tension looks like, data versus discrimination. The other piece that I want to just put on the table for everyone is that we just saw the Department of Health and Human Services release a giant new non-discrimination rule. Does anyone have any idea what rule that was? Come on, folks. Advocates for ourselves and our communities. Section 1557 of the Affordable Care Act. It is the primary non-discrimination provision of the health reform law. It prohibits discrimination in any federally funded health program, activity, or facility on the basis of factors that include sex. And according to this final rule that was released in May of this year, sex includes gender identity and sex stereotypes, as well as they put it, individuals with atypical sex characteristics, or intersex individuals, and people who identify as non-binary, so outside of the male-female gender binary. So Section 1557 provides us with a really excellent opportunity as we're moving forward with initiatives such as meaningful use. We are also trying to make sure that those non-discrimination provisions are developing in tandem, and that members of our community are aware of what are the opportunities for self-identification in healthcare settings, what are the benefits of doing that, and what are the protections that are in place in case something goes wrong, because so many of us are familiar, of course, with situations where it's gone wrong.
Sure.
So I will end my remarks there with that balance between data and discrimination, and hand it back over to Michael.
Thank you so much for that overview. Samantha, same question to you. Give us an overview of the work that you do and how it factors into the topics we're talking about at the conference here today.
So it might seem a little bit mystifying, apparently, that a person who's working in an autistic advocacy issues would be particularly making a statement on LGBTI issues. But I will note that when we end up talking about health privacy issues for people with disabilities, and that includes people on the autism spectrum and people with mental health disabilities, we are going to be disproportionately talking about the LGBT community. In particular, a very, very large, unacceptably large proportion of the LGBT community has a history of seeking assistance with mental health problems. About 40%, for example, of transgender individuals have attempted suicide in their lifetime. Many, many people in the LGBT community will be diagnosed with something along the lines of either PTSD, depression, bipolar, anxiety disorder, and of course for the transgender community there's a separate diagnosis of gender dysphoria that many people do need to get in order to transition. In addition, the autistic community has a sort of a weird trait, which is that it's disproportionately transgender. And no one really actually knows why, but there have been several studies noticing that if you go to gender identity clinics, there is going to be a disproportionate number of people on the autism spectrum there, and if you go to places that provide autism services, there's going to be a disproportionate number of transgender people there. So we definitely are very active in trying to negotiate the intersection of this space. What issues are going to be particularly important when we're talking about this intersectional population? One of them is guardianship, in which a person with a mental disability, either a developmental disability or a mental health disability, is placed under legal guardianship by often a family member or a friend or sometimes the state. When a person has a legal guardian, their health privacy rights are abridged, at least with respect to that guardian, and especially when the guardian is a family member who's not supportive, that can be a particularly difficult problem to navigate, and it can make it difficult for people to access health, mental health, and sexual health services. In addition, we'll see this in the context of mental health reform efforts. There is a mental health reform, a so-called mental health reform bill, HR 2646, that would significantly expand caregivers' rights to access mental health and other protected health information under HIPAA. Right now, it's actually in the process of being reintroduced, and we hear that that expansion would now only cover, it wouldn't cover therapist notes, but it would cover, for example, a diagnosis and treatment plan. Even that can be a really serious problem for, just for an example, a transgender person who's been diagnosed with gender dysphoria doesn't want their family members to know about that diagnosis or their plans to transition. It can also, be a concern for many other circumstances. So that's my statement, and I'll hand it back.
Great, thank you so much. Last but certainly not least, Anne, tell us about the work that you do with the intersex community and how that factors into issues of privacy and what we're talking about here today.
Okay, thank you. And I'll start with the definition of what's meant by intersex, as I generally do, because I find that's a term that not everybody's familiar with, and some people who think they're familiar with it often have the wrong idea. So the community I represent, the intersex community, is people who are born with sex traits or characteristics that are in some way atypical. So when I talk about sex characteristics, I mean the physical markers of sex: chromosomes, gonads, internal sex organs, genitals, sex hormones. These are all things we tend to assume come in only two package models, right? You get package A or you get package B, or you get package F or package M, however you want to look at that. In reality, in the incredible diversity of human biology, there are many more variations than that. So for almost any physical marker of sex, there can be some kind of intermediate, or what's sometimes called by medicine ambiguous form. So for example, people can have ambiguous genitals. That's the word the doctors use. I don't know anyone who feels that their own genitals are ambiguous, but some people have very atypical genitals. People can have different chromosome patterns. So you can have an XY chromosome pattern, for example, which is the typically male pattern, in the body of somebody who externally is born looking entirely female. You can also have chromosome patterns other than XX or XY. So for example, some people have XXY. Some people have XX in some cells and XY in other cells. So there's many, many variations. We're talking about maybe 60 different medical conditions, and many people who are born intersex don't have a diagnosis. What people who are born intersex share, though, is a history of interference and management of their bodies by medical doctors that has often been very harmful and very stigmatizing. So typically, anywhere in the world now, when a child is born intersex, they're generally given, especially if their genitals are atypical in any way, they're given a sex assignment surgery to make them look typically male or typically female very early in life. And often those assignments turn out to not match their eventual gender identity. Even when they do, they can be incredibly physically damaging. So the main issue, that's a very brief nutshell background of what the community is. So talking about this, I was kind of mystified, honestly, at first as to why this would be an issue at a health privacy summit. Certainly for the intersex community, privacy is a very important issue, and it is often that I'm contacted by people who want to know how they can access medical care and still keep their information private, because it's a condition that has been very stigmatized, and a lot of people don't want to encounter that stigma. But for the most part, for the community, the way I interact with privacy the most is about decisional privacy and autonomy, about privacy in the sort of larger constitutional sense that's about people's right to control their body. So the main issue for this community historically has been the desire to make their own medical decisions and not have people make irreversible decisions for them before they're able to even engage with those decisions. And that is the main issue that I work on. That said, and as I've been engaging with this conference, does that mean I'm out of time? Or
No, I pushed.
Is the net coming out? All right. That said, I'm really interested in the way this topic is being approached at this conference in terms of the tension between big data and health privacy. Because certainly privacy is a big issue for this community and for any community that has any kind of diagnosis that might be stigmatizing. And one of the reasons we see this very harmful medical treatment continuing after decades and decades of people within the community speaking out, saying they're not happy with the treatment that they received, is because there's almost no data on the conditions at all. And what we're told repeatedly by doctors is we can't change the way we're treating intersex people because we don't have any data to know whether or not what we're doing is harmful. And really, there's very little data. For example, I've been doing this job for 10 years. People ask me all the time, well, how many of these surgeries are done every year in the United States? We don't know. Nobody knows. That data is not kept. How often does the gender assignment turn out to be wrong? Again, no one knows. And so we are pushing very hard for an evidence-based model of medicine, but you can't get that evidence model without aggregating data. And so we have a community here that also sees how harmful it is not to have data. So yeah, I'm interested. I'm interested in your project, Kellan, about trying to get more data gathered. We have been interacting a lot with people from the LGBT community about how do you gather data on intersex people? How do we start to know sort of how many intersex people are out there, how they're being treated, how they identify? Because a lot of people don't identify with intersex as a term. And I should say also, a lot of the intersex community doesn't necessarily identify with the LGBT community, although the LGBT community tends to be the group that will add the I and sweep the intersex into their mission, and often will come to intersex organizations and say, how do we respectfully include your issues, which, frankly, no one else is doing. So we end up at the table with the LGBT groups, despite the fact that a lot of people within the community would say maybe we don't belong there. That is where this issue gets swept in. So I guess that's my brief overview, and I'm happy to answer questions as we go. I
want to take a point that Anne talked about, just the lack of data, and I'll ask Kellan this question based on the work that you're doing, trying to collect data and some of the issues associated with that. So I'll just throw this very direct question out there. Why is it so hard to collect data for the LGBT community when we're talking about healthcare? What are some of the basic issues that you face when trying to collect data for this particular community? And why is it so hard to do so?
I think the first one that I would say or that comes to mind is really obviously related to our conversation at this conference, which is that people are concerned about having that information available. Mm-hmm. People want to know how it's going to be used, where it's going to go, who's going to see it. We are not in an era in which people can freely identify as LGBT and expect not to experience or encounter discrimination. Especially as we were mentioning some of the states that are explicitly targeting LGBT individuals for discrimination on the basis of their sexual orientation or their gender identity. So having that information out there is something that a lot of people are very afraid of. And this clearly comes, too, from the history of interactions between LGBT communities and the medical community. Homosexuality was, of course, stigmatized as a mental disorder until 1973. Gender identity disorder, gender dysphoria, is still part of the DSM. I personally believe that the narrative around we need to remove these diagnoses because otherwise people are stigmatized, I think that's very problematic because we should not be talking about mental health diagnoses as inherently stigmatizing. But the fact remains that the medical community has frequently used these diagnoses as a weapon against LGBT individuals in order to control LGBT people's bodies, their identities, and to frequently attempt to make sure that they are not able to express themselves as who they really are, particularly in the case of transgender individuals, but certainly gay individuals, gay, lesbian, and bisexual or queer individuals also being subject to, for example, conversion therapy, so-called reparative therapy that attempts to change their sexual orientation or change their gender identity so that they are no longer LGB or T. So I think that history of fear and mistreatment in the medical community and between medical providers and LGBT individuals is a really big component of why it is so hard to get these data. I think another big issue is that we don't necessarily know who we mean when we say we want to collect data on the LGBT or the LGBTI community. Whom do we mean? Do we mean individuals who would identify themselves as LGBT in a way that is frankly pretty politically charged today? There are about 9 million people in the United States today who identify as LGBT. That comes from the Gallup poll in 2012 to 2014. But that really is a significant undercount on the basis of what we know about who experiences same-sex attraction and who might have sex with someone of the same sex. So thinking about who is willing to identify themselves as LGBT, what does it mean to ask people to do that? And even just looking at the concepts of sexual orientation and gender identity themselves. Sexual orientation, for example, has at least 3 different components: attraction, behavior, and identity. Which one are you measuring and why? Gender identity has multiple dimensions as well. There's the sex that was assigned to you at birth, similar to what happens with intersex individuals in the sense of the doctor taking a look and deciding, well, this is what it's going to be, sex assigned at birth, as distinct from what may be somebody's gender identity, which is the gender that they know themselves to be, the same way that any of us wake up in the morning and recognize, know ourselves to be male or know ourselves to be female or know ourselves to be some other gender. That is gender identity. That is distinct for each individual and is not always possible to kind of come up with one single easy standard to say, all right, you're transgender, you're not, you're gay, you're not, you're bisexual, you're not. What are the standards that we're using to determine who fits into those boxes? And how narrow are those boxes? There are plenty of us in LGBT communities who have had quite enough of boxes in our lives and don't really want to be pushed back into them. Even for the sake of something, if we could come up with a really good way to describe why data are so important, there is still that resistance, I think, for many of us to allow ourselves to be distilled down to some tiny little check mark in a tiny little box.
I wanted to ask Samantha this question too. It seems like your work tends to focus on a lot of what one might describe as intersectionality of people with mental illness, and then you have LGBTI, self-identified LGBTI folks involved in that. So talk a little bit about that, and then I'm curious to get your thoughts about how these anti-LGBT laws we've seen, such as North Carolina, Mississippi, Tennessee, all of the ones that are getting a lot of attention, how do those directly impact the people with whom your organization works, and does the intersectionality of their identity make that impact even more acute?
Yeah, I will say, one thing that's also going to prevent people from getting good data is that a lot of people with developmental disabilities or intellectual disabilities are simply never asked any questions about their sexual orientation, gender identity, sexual behavior, sexual health, because the population is assumed to be sexless or asexual. Similarly, a lot of people with physical disabilities will report the same thing. They'll simply not be asked these questions. They won't be prompted to self-disclose, and we're really going to miss out on data about that population. In addition, there's something that we would sometimes call the trans broken arm syndrome, where especially this is something that I find especially reported in the transgender community. If you are transgender and you disclose that you're transgender, every single other thing that you might be seeking health care for is then attributed to the fact that you're transgender and not treated as a specific issue. I have a friend who has bipolar disorder, is transgender, sought out a psychiatrist for bipolar disorder. She just needed someone to prescribe her meds. And the psychiatrist said something along the lines of, "Oh, I'm sorry, I don't do gender. This isn't a gender clinic." And she's like, "Well, I transitioned, 10 years ago. I'm not actually asking for transition counseling. I'm asking for help with bipolar." But the therapist said, "Well, never mind. I don't do transgender patients." So a lot of transgender people are especially not going to want to disclose in mental health contexts or even some physical health contexts because their health problems will then be attributed to the fact that they're transgender or the fact that they're taking hormones. So we have a lot of that. As for the impact of a lot of these anti-LGBT and anti-transgender laws, one thing that is going to be particularly important to the intersectional population is, first of all, the fact that people with disabilities often are going to be using state services a lot more. So when HB2, for example, it's focusing a lot of its restroom prohibitions on state-owned facilities. That's going to be really a particular challenge to anyone who particularly needs state-operated services. Going to be spending a lot of time in their state health and human services trying to apply for Medicaid or for example. And we also are seeing this a lot in the context of people who they're going to be standing out both because they're disabled and because they are LGBT. So you're going to see a lot of situations in which someone who is for example using the restroom that they that matches their gender identity, if they can't access the same kinds of transition services, in part because of their disability status, they might find themselves more visible, and they might find themselves disproportionately targeted for enforcement of those laws. So those are the types of things that we're really concerned about.
And same question to you, talking about the legislation we've seen. How has the intersex community been affected by what's going on, say, in North Carolina and Mississippi? Give us a sense of just the impact these laws have had on the intersex community in terms of health, privacy, and data, things like that.
Right. It's a little tricky, honestly, for me to relate it exactly to health privacy, but I'll do my best. In terms of the kinds of stigmatizing laws we've seen coming out, I think that has a dual effect. One is it heightened people's fear of being outed and exposed. So a lot of intersex people have effectively sort of flown under the radar in many ways in terms of public awareness. And with these laws coming out that target largely the transgender community, but often by their terms include the intersex community as well, it's been both very frightening for the community, but it's also been a situation where we've seen the visibility of intersex issues really raised. So as the media reports on this, as people talk about it, they're talking about the fact that it impacts intersex people as well as transgender people, and that visibility has been very good for the community. I think the intersex community, more than any other one, has really seen how invisibility can be very, very damaging to a marginalized or stigmatized community. So in the past, the medical protocols I described earlier were developed with the intention that people would not know themselves to be intersex and that nobody else would know. And in fact, I know one intersex person who was born about almost 60 years ago. When she was born, her mother was sedated for 3 days in the hospital so that she would not know that she'd had a child with atypical genitals until they figured out what to do. And often medical records were hidden or destroyed. It was instructed in medical records not to deliver records to the patient. And this is one reason why, when I go and talk about intersex, in spite of the fact that it's estimated to be about 1 in 2,000 people in the population, many, many people don't even know that intersex people exist. So as long as that's the case, there's been a sort of purposeful erasure of this population from the community. And as long as that's the case, there's no way for people to organize, to share stories, to find out that they're not the only one. And so what we've seen is that visibility is really a lifeline. And of course, this is something the LGBT community learned 20 years ago with the silence equals death, it's really true for the intersex community as well. So even visibility that starts in something negative like a bathroom law can leads to people recognizing, for example, if the young people I work with, and I work with a group of intersex youth, they can go on Facebook now and they see these negative laws, and they also see all the people posting against those laws. And they see all their friends who are saying, this is terrible, and it could impact intersex people too, and I don't want my intersex friends discriminated against. So it's in some ways it opens doors as well as closing them. The SB 1557, it wasn't an SB, but the 1557 rule, the sex discrimination rule that just came out, also explicitly included intersex people. And so we now have the opportunity to see what it means to have sex discrimination defined as including discrimination against intersex people. Relating it back to privacy, I mean, I think it both increases the importance of keeping people's medical records private, as it also highlights the importance of making this data publicly available so we can start to see how many people there are out there that are affected by this issue and what's happening to them.
And this will be my final question, then we'll open it up to folks in the audience. SB 1557 has come up quite a bit in this conversation, so I'm just wondering, real quick from the panelists, what are some other best practices, both from this country and around the world, if you're aware of anything that's been happening internationally that would help improve not only data collection, but just issues of privacy related to the community? Any quick thoughts on best practices that happen?
HIPAA has actually been great for this community, in spite of the trashing that it's gotten at this conference, which I can understand why it's looking at it from a different way. HIPAA's been great both because when you have a stigmatized but interesting condition, it is very difficult to convince healthcare providers to keep a person's privacy, to keep gossip out of the halls. So having actual regulation with fines, with teeth attached to those fines, because I do teach doctors about HIPAA a lot, and doctors fear HIPAA violations because they know it comes with a big fine. So I would say, I mean, that seems to me to be a very important lesson in, if you want to preserve privacy, there has to be meaningful enforcement, and putting that meaningful enforcement in the hands of the people whose privacy is violated, I think is very important. But it's also been very useful in terms of getting people rights to their medical records, because as I said, this information has been hidden a lot from people with intersex traits, and it's been very important to people to be able to ask for their medical records and actually get them, because there is actually a legal right to have those records. I understand HIPAA in that regard doesn't have all the teeth that it needs, but it's a good start.
Kellan or Samantha, anything you want to add to that?
I would second about HIPAA. HIPAA is extremely important to people with mental health and developmental disabilities, especially those who are trying to keep their health information private from a caregiver, either a family member or someone who's sort of self-appointed as being their caregiver. A lot of the time there is a bias toward trying to collaborate with the whole network, and that is reasonable if it has the consent of the actual person whose health records that is. But we have a lot of adults with disabilities who struggle to maintain the privacy of their health records from the eyes of sort of prying family members who are very used to taking over that person's health care and not necessarily being shut out. We often promote what we call supported decision making, where if a person does have a mental health or developmental disability issue and they do need support in order to make health decisions, they're supported to appoint a supporter and to really exercise decision making over what information does that supporter have? Do I allow the doctor to speak with my supporter, and to make sure that the supporter is like an actual person who's chosen by the person with a disability, so that person can maintain privacy from other family members that they might not necessarily want to share their status with.
Any quick thoughts, Kellan?
I think the main thing for me, and this works I think a little bit differently from sort of the perspective from, for example, an intersex perspective, is trying to normalize data collection Well, I guess it actually does intersect with a lot with what you were saying about trying to make information about the fact that intersex people exist, making that information more widely available. And I think the same is true for LGBT people. More Americans believe that they have seen a ghost than have knowingly met a transgender person. And we know that familiarity with gay people, actual individuals who are gay, is one of the biggest things that has been driving the social changes and the legal changes that we've been seeing that are really actually supportive of LGBT people. So, for example, the Section 1557 of the Affordable Care Act rule that protects LGBT people from discrimination. So I think that that is probably the biggest thing that I would focus on, is the efforts to, or initiatives to try to say, everyone has a sexual orientation. Everyone has a gender identity. There are folks whose gender identity or sexual orientation is stigmatized in some way, and getting more information out there about the degree to which there is diversity in the range of identities around sexual orientation, around gender identity, whatever we mean by those terms. I think that that is something that is really important, even as we do so in the context of trying to make sure that these data don't get away from the people that they come from and are not used against us in situations, particularly when we're seeking access to benefits or services.
Great. Well, thank you so much. And I want to take the last few minutes of the panel to open it up to questions. I know that I think you had a question. So if you could just state your name and your affiliation and the person to whom you're directing your question.
Okay, so my name is Tina Curtis. I'm with the Office of the Attorney General and Privacy Enforcement for the District of Columbia, and this is just fascinating conversation. And just had so many questions, but let's just sort of narrow that just for the sake of time. I'm wondering about, we talked about best practices. I'm wondering, as we do HIEs and data sharing, if there's special considerations, certainly mental health, there's certain issues that immediately come to mind in terms of sensitive data. This certainly sounds like one of those categories, but it's not been carved out as such. And I'm just sort of wondering if there are any recommendations for that. And then you stated something about atypical, I guess, chromosomes.
Mm-hmm.
And I'm wondering about whether insurance pays for that, for those types of diagnoses, so to
Mm-hmm.
speak, because intersex is a new category for me. I just learned something
Mm-hmm.
today, so I just wanted to know about what the insurance community is doing with that.
Go ahead.
You wanna,
You start.
as far as the question about HIEs and information exchange, the project that I run at CAP in partnership with Fenway Health, which is a large federally qualified health center in Boston, the Do Ask, Do Tell project. So it's doaskdotell.org. And that is the project that we have done a lot of our work on meaningful use in order to figure out what does it look like to facilitate the standardized capture of electronic data on sexual orientation and gender identity. So there are suggested best practices for what those questions could look like and what the answers, right? Because in order to have these structured data, you need sort of pre-populated answers, or you need some ideas about how you're going to describe the answers that people give. So we do have information available there. And one of the things that we would love to do is expand that conversation in the HIE space. There hasn't been a lot of work done on that front. We have been mostly focusing on trying to narrow down how do we think these questions are best asked in an electronic record in particular, and in a healthcare setting in particular. And so now that we have a better sense of that, in the meaningful use requirements from last fall, the stage 3 meaningful use requirements from last fall, we are looking to expand out our understanding of how to do that in the HIE space. And as far as how to treat these data with regard to confidentiality, it's a lot of tension. I feel like I kind of just, the balance, right? The scales of justice or something. Things in balance, big data, non-discrimination, and privacy. And similarly, we think that these data are fundamental demographic characteristics. They describe aspects of who we are as people that are similar to our race, our ethnicity, the primary language that we speak, whether we have a disability, etc.